Sometimes that issue is in the tissue. The connective tissue in your body oftentimes is a generator of pain, from something like Ehlers-Danos to POTS, even to different hypermobility disorders. Hypermobility issues and connective tissue can drive lots of pain in the person with endometriosis, things you might not have even thought about. So join Dr. Linda Bluestein, the Hypermobility MD, and us, the Endometriosis Summit, to learn more about connective tissue disorders and endometriosis. Good evening, Endo Summit Live, and welcome to this very exciting new topic for the Endometriosis Summit: connective tissue disorders and hypermobility. We are so pleased to welcome the Hypermobility MD tonight, Dr. Linda Bluestein. Welcome, doctor. Can you tell everybody a little bit about yourself?
Sure, absolutely. So I am an anesthesiologist, and I grew up having lots of aches and pains and allergies and numerous medical problems, asthma and all kinds of things, migraines, and nobody could figure out what was going on, and was able to, successfully get through medical school and residency and work for a number of years. But things kept popping up off and on. And finally, I was diagnosed with hypermobile EDS after many, many, many years of not knowing why I was experiencing all of these things. And so now my whole goal is to try to inform patients, healthcare professionals, as many people as possible about these conditions, because it's very common for people to have the symptoms dismissed. People don't understand how could these things possibly all be related. So they are often told by their doctors, well, that's just not possible. And other similar kinds of comments, so I really just have taken my life experiences along with the education that I have, and I started a podcast, and I still have a small private practice, and I belong to a number of different nonprofit organizations and things like that, in an effort to raise awareness and spread the word as much as possible.
Yeah, and you really have. You have a podcast called Bendy Bodies, and we had you on our podcast. And in having to learn and to study connective tissue disorders, I listened to all the Bendy Bodies, and it's very tedious, but they're very informative because it's a topic not enough people talk about enough at all. I wonder, you were an anesthesiologist, you were going through med school, you were practicing as a physician. What was it like for you to be in so much pain and have so much of your life compromised, and for no one to really hear you?
To be honest, it was horrible. It was really, really horrible. My partners treated me very, very poorly. Most of them, not all of them, but most of them. And I got the suck it up buttercup, from them, as well as from my own doctor, who I kept telling him, I feel like there's something wrong with me. I get injured. I remember this like it was yesterday. I remember telling him I get injured way too easily, doing very much everyday types of things. And then once I get injured, I don't heal well. And there must be some reason for this. And I got, you're fine, you're fine. I went through a period where I was so feeling down on myself, blaming myself, feeling, a real lack of support. I lost a lot of weight, and that was still completely ignored, even though, now I had some other like physical signs of things that I was, struggling. And it was a really, really hard time. It was a very hard time. Yeah.
It wasn't Bendy Bodies, but it was a different podcast. And I just was struck by how brave you were to come out the other side, because it reminds me, I also came out the other side to the Endometriosis Summit. So like when I find another, I'm always like, I feel like we're meant to meet. but I think also connective tissue disorders are so misunderstood. Where would you begin with this topic? What would be your introduction to what connective tissue disorders are?
Right. So usually, so I was also a former dancer, and I studied ballet for many years, and that was my real love. That's what I really wanted to do, was have a career as a professional ballet dancer. But I had to pivot early on because of my health issues and pain and surgeries and things like that. And so I often start though with explaining what hypermobility is, and then explaining about the subset of conditions related to hypermobility that are connective tissue disorders. So is it okay if I kind of go through that then?
Yeah, I think a
Okay.
lot of people, so, you are doing the workshop for Endo Summit workshop,
Mhm.
but a lot of people, maybe they know one connective tissue disorder, or maybe they know, but they don't understand there's like a lot going on. So that would
Right.
be great if you wanted to go through them.
Sure. So hypermobility simply means that at least a joint has greater than average range of motion. And that's all that it means. It's a descriptor, not a diagnosis. And we now know from the 2017 International Consortium new criteria, we're dividing joint hypermobility into several different types. So you can have peripheral joint hypermobility, meaning that you have hypermobility in your hands and your feet. You can have localized joint hypermobility. So maybe you just have hypermobility in your shoulders. Or if you have more than generally five joints, then you have generalized joint hypermobility. And the last category is called historical joint hypermobility. And that's when you used to be hypermobile, but you're not anymore. Part of the challenge with these conditions is that there's a timetable that people generally follow. And so oftentimes when they're young and maybe they're doing gymnastics or ballet, something like that, where being hypermobile can actually be an asset. You can have those beautiful lines that people are striving for. And at that time, most people are not symptomatic, so they're not experiencing any problems. But by the time people are developing more symptoms, oftentimes they're not hypermobile anymore. So it's very confusing. And like with most things, the devil's in the details. So amongst this category of symptomatic hypermobility or hypermobility disorders, there is a significant, huge number of different things that can cause those. And one of those big basket categories of things is connective tissue disorders. So connective tissue disorders usually means that there is a genetic defect in the genes that produce the proteins in the extracellular matrix, collagen, other things that comprise our connective tissue. And so what ends up happening is our connective tissue is all throughout the body. So this is why these conditions can cause symptoms everywhere in the body, and it can be very, very confusing for clinicians that are not familiar with these conditions.
We're going to take just a second to welcome the better half, or the other half of the Endometriosis Summit, which is Dr. Vidali. Dr. Vidali, meet Dr. Bluestein.
Hi.
He's having some technical issues so far today, but we're going to go with it. So I wonder, there are lots of big umbrellas when it comes to connective tissue, and people talk about EDS, and people talk about mast cell activation, and people talk about dysautonomia and POTS. Do you want to take a stab at defining those for our crowd?
Sure, definitely. So underneath the umbrella of connective tissue disorders, and I want people to know that, okay, so there's the umbrella of connective tissue disorders. The umbrella of hypermobility disorders is above that. Connective tissue disorders is a subset of hypermobility disorders. Not every hypermobility disorder has a defect in connective tissue. So if you have a defect in connective tissue, you could have one of the types of the Ehlers-Danos syndromes, of which there are now 14 subtypes. You could have something like Marfan syndrome. You could have Stickler's. You could have something called Louis-Dietz. There are a number of different connective tissue disorders that exist. There are specific criteria for diagnosing, each one of these things. Osteogenesis imperfecta is another example, of which there are different subtypes of that. So it gets complicated pretty quickly. We know that there is a common overlap between connective tissue disorders, especially the Ehlers-Danlos syndromes, which are amongst the more common types of connective tissue disorders, and things like dysautonomia, which dysautonomia is the bigger umbrella under which POTS sits, and mast cell activation syndrome, which is a subset of mast cell activation disease or mast cell activation disorders. And one of these days, somebody's going to make a beautiful chart with all of these on the same page, but it's very, we don't
one
really,
of these days, or you're going to do it. I
Yeah.
think you should do it.
yeah, it's confusing because, just because things appear to be correlated, we don't necessarily know what's cause and effect, right? So there was a really good paper written by Lawrence Afrin recently in the American Journal of Genetics, a supplement, I believe it was November of 2021, so last month actually, about, is MCAS or mast cell activation syndrome, is that at the root of a lot of cases of EDS? So because of what happens when mast cells, I'll back up. So mast cells are present in tissues where we interface with the environment. So they're in our skin, they're in the entire gastrointestinal tract, from our mouth, through mouth, oropharynx, in the esophagus, in the stomach, all the way through the colon, et cetera. And they're also in the vagina, they're, in the lungs, they're every place where we interface with the environment. And they're an important part of the immune system. And they are supposed to react under certain circumstances. And now because of COVID, we're hearing more and more about mast cells than we used to. I think probably most people didn't even know what they were before, but now more people are becoming aware of them. If you have mast cells that are kind of trigger happy, they react very easily, then what happens is they degranulate, or they burst open and release their contents more easily than they're supposed to. Well, we know that mast cells contain hundreds of different mediators, all of which have effects all throughout the body. So very quickly, you can see why people can have lots and lots of different symptoms from mast cell activation syndrome. And a lot of us have heard of histamine, but histamine is only one of the contents of mast cells. And this is partly why people often they will improve with antihistamines, but they might not get a complete resolution of their symptoms because it's not just histamine. There's also heparin and, prostaglandins and all kinds of other things that are present inside the mast cells. Tryptase is one of the more specific ones that we can measure in the blood. And we can also measure during a flare. But mast cells are very, very important. So we have the connective tissue disorders, then we have the basket of dysautonomia or disorders of the autonomic nervous system, and that's what regulates all of the automatic functions in our body, the heart rate, the blood pressure, our digestion, our temperature control, all of those kinds of things. And then we have the mast cell disorders, and they definitely appear to overlap, but we don't know necessarily what causes what. And so the 2017, when they came up with the international criteria, especially for the hypermobile type of EDS, which we don't know the genetic marker for yet, they specifically left out those comorbid conditions because they knew that it would really cloud the picture and make it much harder to establish these diagnoses in a more accurate way. And part of the goal with these criteria was to find the gene the gene or genes, I should say, responsible for the hypermobile type of EDS or the phenotype of the hypermobile EDS. So there's a lot of work that needs to be done, but it's very exciting because, there's a lot of people that are really making good progress in this area.
So Dr. Bluestein, I don't know if you've interacted a lot with me for the Endometriosis Summit, but Dr. Vidali not only is an endometriosis surgeon, he's an immunologist. So he really and he does reproductive immunology, one of the few in the country. And I've been helping him. He owns a separate company called Progestins. And when you talk about mast cell activation syndrome, all I can think of is its impact on fertility, because if those cells are opening and spilling their guts everywhere, you're definitely disrupting the balance of what needs to go on for implantation. But Dr. Vidali, how often, there's so many we could talk about, but how often do you see mast cell activation syndrome in the endometriosis patient? And how do you think it affects, I could talk about how it affects somebody recovering from surgery, but how do you think it affects their profile of healing and healing from the endometriosis?
Well, let me just, first of all, good evening. And I apologize for that late entrance with that picture. Somebody else used, Dr. Pigazzi used my Zoom. So, of course, all sorts of weird things with the pictures of surgery. So I apologize for that. First of all, good evening. And Dr. Bluestein, fantastic to hear you speak. Fantastic, very exciting. And the reason why I'm so excited that you're here with us tonight is that because there's such limited resources, at least I believe, for people to actually learn more about this. As we're talking tonight, maybe we'll talk a little bit more, and I have more questions to ask you. But certainly going to the reason why things are confusing is exactly what you just said, is because there's a lot of crossover between these different conditions, and most people and doctors, they want to fit people in a little box, right? They want to put people in a little box and tell people, okay, you have the classic POTS, you are the classic mast cell activation syndrome, but most people are not classic in their presentation, and because they're not classic and they cannot be fit into that box, then you end up with a no diagnosis. Doctors end up telling you you're fine, and really, what the heck? The patient knows that they're not fine, right? But it's a typical situation where all the tests, some of the tests are abnormal, but they cannot be fit into that. They don't meet the criteria that have been set. And I think this is one of the biggest problems that we see. We see this in the pain arena, and we see this also in the fertility arena. The same problem, which is if the doctor cannot fix, and who is the doctor that takes care of this? Is it the rheumatologist?
Right.
Is it the allergologist? Is it the neurologist? The answer is neither or all. That's what it is.
The Endometriosis Summit's answer is the anesthesiologist takes care of it, and it's Dr. Linda Bluestein. But I have to say he's right, because the number one asked question we got to ask you was, how do we find somebody to help me? That's what I have like 10 DMs that all say, who do I go to? How do I find them? And then lucky for you, they all said, does she do telehealth? So now we can do that. Yeah.
But as I was, and thank you for saying that, Sally, because ultimately, Dr. Bluestein, really, this is really what it comes down to. How does a physician, because, of course, our appeal, the Endometriosis Summit, is both to patients, but also to physicians. How do physicians get informed? How do physicians learn about this? And we'll talk about more in detail, but, really, there's a lack of sort of preparation because, from a educational standpoint, from physicians, they don't even know what's going on here. But if a patient, if an individual finds, thinks that they have this problem, the reality is that it's almost impossible to get access to care. If one thinks they have EDS, good luck in entering an EDS center. They'll tell you, well, you're not a child, we don't want to hear from you, or your symptoms are mild, you're walking, fine, we don't want to hear, you have a mild case, there's not much we can do for you. So really, good luck if you try to get into an EDS center, unless you are connected, you have people that somebody who knows somebody. Isn't this what's going on? Isn't this what?
Right. And we're working on developing some EDS centers in the US. There is an EDS center in Canada, in Toronto. But even people, the grandfathers of EDS both Drs. Hakim and Graham are in the UK, and I get messages all the time from people in London that they're on a waiting list for 5 years, and Dr. Hakim is amazing and lovely, and I've spent much time talking with him and am on committees with him and things like that. But, he can only see so many people. He's doing a lot of administrative things now, trying to really, educate other doctors so that, other people besides him can see people. But yeah, it really is a huge problem. We need to get more people aware of what these disorders are. And I say all the time, it doesn't matter what your specialty, you will see these people in your practice. And if you understand what these conditions entail, and you understand that, okay, there's no cure, but there are things that you can do, it will make your life and the patient's life better. When I got my diagnosis from a rheumatologist, and I totally agree with you, Dr. Vitale, that, part of the problem is, where is the home for these patients? Is it physical medicine and rehab? Is it rheumatology? Is it neurology? Who is it precisely? And that's where it runs into a lot of difficulties. When I was diagnosed by a rheumatologist, he said, I don't need to see you again. Good luck. Handed me a little handout on it, and that was it. And he said, there's nothing you can do. This is what you have, but there's nothing you can do about it. Good luck. So yeah, you're right. I mean, those are some of the real challenges that people face.
Go ahead, doctor.
When it comes to obviously we're all about endometriosis. When it comes to endometriosis at the Endometriosis Summit, but not only, but we are the Endometriosis Summit. When it comes to endometriosis, what do you think is this? Why is there such an association? Is it just an association, or are there causative, or is there a causative connection between endometriosis and EDS? What is your opinion, doctor?
Well, this might not be a very popular opinion, but from what I've read, it's really hard to say at this point in time. We don't have a really good recent study that we can point to that was a large study where we can say having EDS increases your risk of endometriosis, a certain fold, right? I'm not even going to say a number because I'm afraid somebody's going to misquote that. What we do know is that in order to have endometriosis, your gender has to be female. And we know that EDS affects many more females than males. So I believe that part of the reason why it appears that they occur more commonly in the same body could be related to connective tissue. And definitely we could find something, there, but it could also be related to hormones. If we have a male who is undergoing sex change and is getting female hormones, oftentimes they will become more symptomatic. They will start developing more pain and have more problems related to their EDS. And if it's a female that's taking testosterone because they're undergoing that hormonal change to become, the male features, they often will experience a lessening of their symptoms. And we do know that mast cells have hormone receptors on the surface of the cells. So again, there's a lot of different factors that can be involved here. And I don't want to, you may know the statistic better than I, but I couldn't find anything that I could really hang my hat on other than, the endometriosis and EDS was at the population rate of 6 to 10%. And that was from a 2018 study. Part of the problem being that in some of the earlier studies where they found higher percentages, they were making the diagnosis of endometriosis based on symptoms and not based on, something that was more definitive. So,
if you watch, and you'll get to meet him, whether we're in person or virtual, and time will tell, but Dr. Redwine is coming to the Endometriosis Summit, and he talks a lot about the origin of endometriosis. And he was our keynote last year, and I watched really in depth his video. It's on YouTube about how the tract of endometriosis gets laid down in utero. And when you see this tissue be sort of left over from this embryological development, it makes me think of, did something go wrong with the connective? And we don't have any proof of this. We're just three professionals talking, but it makes me think, was the issue with the connective tissue right then and there in embryological development. Because when you watch him do these tracts on YouTube of real embryological development, you can see these pieces be left behind, almost like connective tissue falling apart. That's, I always wonder about that. Am I crazy, Dr. Vidali, or are you just like, you're off your rocker?
Well, I think that we like you said, we don't know. I think it's an interesting theory, Sally, but just like what Dr. Bluestein just said, I think the reality is that we don't know. And I think one of the issues is what comes first, the chicken or the egg? I think when it comes to pelvic pain, I think in some cases, the source, it's a mixed source in some individuals. It could be a combination of the EDS and the lassitude of the ligaments that ends up with a hypermobility and nerve damage, and that causes pain. Or it could be the endometriosis. And sometimes people who have the lassitude, and so that's really it's like the tissue, the lassitude of the joints, and they end up having surgery for endometriosis, whereas maybe the treatment would have been addressing whichever way possible the other problem. So I think, and in other cases, individuals with endometriosis with EDS, they tell them there's nothing you can do, but in reality, the pain comes from the endometriosis. So I think this is one of the problems when you have these two conditions that are living together, which may or may not be, correlated. They may not be associated genetically, but it could be just there's some immune dysfunction that may be associated in endometriosis with. I would look more at the immune system personally. I think that when you have an immune system and inadequate immune surveillance, you have easier way for these lesions to grow. I mean, they're there, but they grow more, of course, if there's less immune surveillance. So I think that may be another reason. But it's a difficult call from that perspective. And this is really when it comes down, when you're talking about, kind of like changing gears and talking about some of the symptoms that you described, doctor, the bloating, when we talk about flares, there's different theories about the origin of, this bloating that, is in common parlance in the people in the knowing endometriosis called the endobelly. You may have heard this term before. And people always asking what causes the endobelly. I mean, because really it's a factual event, right? But what is the cause of that? Could it be like that it is actually a some sort of an immune activation, a mast cell release at the level of the intestine, or the intestinal at the colonic level, but even possibly also small bowel? And could that be one of the reasons? Could that be something that is it something that makes sense, what we're saying here, what we're hypothesizing, doctor?
I definitely think so. When I go through, quite a few different systems review with my patients, and, often do address symptoms like bloating, postprandial or, post-meal abdominal pain, and small intestinal bacterial overgrowth, or SIBO, is something that people with EDS are at increased risk for, in part because of the bowels being able to be dilated more and slower transit time, which is quite a common thing. And so oftentimes, if they do have that bloating, I will treat them, I will treat their mast cells, depending on what else is going on in that person, the whole clinical picture. But I do find quite often that bloating type symptom will improve by stabilizing the mast cells.
And how do you do that? How do you stabilize mast cells?
Through a combination of usually supplements, sometimes prescription medications, through potentially changes in the diet, through changes in the environment. I've had people who said, yeah, I have a cat at my house, and when I go live and when I go stay someplace else, I feel a lot better, but they don't want to get rid of the cat, or, give the cat to another family member or something. But sometimes we see that there is a combination of factors that is causing the mast cells to be unhappy. So it might not be one single thing, but some of the things that you're breathing in addition to what you're eating, because I think oftentimes it's common for people to get really focused on what they're eating. And we have to remember that we're also breathing, and there's a lot more things in our environment than there used to be. We spend more time indoors, and our buildings are very well sealed. So we have a lot more indoor pollution than we used to have. So there's a lot that we can do environmentally. Part of the real challenge with mast cell activation disorders is that stress activates mast cells. And so when we tell people you're crazy, I don't know, no, there's no such way that could be true. What happens? They're going to get more stressed, and then that's going to cause more problems, likely more problems with their mast cells. So if we listen to people and we say, even if we say, I believe you, but I'm not really sure what's wrong, but let me see if we can figure this out. Let me see if I can send you someplace else because I don't know what to do with this, but maybe I can find someone else that can help you. If they feel validated and if they feel heard, then that is going to help lower their stress levels, which will help with pain. It will help with their mast cells. It will also help with if they have dysautonomia, because we know that stress makes dysautonomia worse.
Yeah, I find it fascinating because I didn't know when I crafted Endo Summit workshop, but right before you goes the workshop on SIBO, right?
Oh.
We have a gastroenterologist who specializes in endometriosis and SIBO coming, right? And then right after you, we have somebody who's talking about trauma, because obviously when you have all this go on, we have trauma. When we did the podcast together, I was stunned in some ways. The symptoms of a lot of the connective tissue disorders, pelvic floor dysfunction, right? We talked about that. Urinary urgency and frequency, bowel, either bloating, constipation, or diarrhea, right? And then you had heart palpitations, joint aches, but we see all of this in endometriosis. And sometimes we just assume it's endometriosis, right?
Mm-hmm. And there's a really, I will have it in my talk, but there's a great graphic that shows the three overlapping circles with EDS, POTS, and mast cell activation syndrome, and the different symptoms that are most predominant in those conditions. And then there's this area in the middle. It's a Venn diagram, basically. So they're overlapping, and in the middle, all three of them overlap. The symptoms that are in common with these things are quite significant. So as Dr. Vidali said, it can make it very hard to sort out what is this person's underlying problem, because we really want to treat the root cause if we possibly can, rather than just, that's part of my frustration with more traditional Western medicine, is because we only have 5 minutes to see the patient and write our note, then we end up writing a prescription, and maybe on the next visit, we write another prescription to offset the side effects from the first prescription. And then at the third visit, we write another prescription. And, and I've seen people that they're on a lot of different medications, like, okay, let's see if we can get rid of some of these, because they all have excipients, meaning quote unquote inactive ingredients, but those inactive ingredients can cause degranulation of the mast cells. So it's important to try to address things at the root cause level if we possibly can.
I have very bad Hashimoto's, and I think a lot of people in the endometriosis infertility world do, but those inactive ingredients that are supposed to be innocuous, I have to pay no insurance, no nothing for custom compounded thyroid meds, because whatever that inactive ingredient was driving my system nuts. Do you see that a lot with people?
Actually, we see it not uncommonly. And like I said, sometimes I always love it when people come to see me and they're not on a ton of medications, because if they are on a lot of medications, one of the first things that I will often try to do is to try to get them to, let's see if we can get you off of some of these things before we can switch you to some other things. And I've heard it said like this, and I think it's very true. Starting a medication is like a marriage, and stopping it is like a divorce. Even if people feel like something is not really helping, it's it's hard, and I get it, even if there are no real withdrawal type symptoms, which we know that things like SSRIs or SNRIs, selective serotonin reuptake inhibitors, or selective norepinephrine reuptake inhibitors, antidepressants, typical antidepressants, can have definite withdrawal syndromes. The body gets used to these medications. So when we stop them, we can experience unpleasant side effects. And so I get that it's hard to stop things, but it can start to become very messy and very hard to figure out are the side effects that this person or these symptoms that this person is experiencing from the condition itself, or is it potentially from one of the medications? Because some of the medications cause very similar symptoms. So,
yeah, lots of questions tonight on what could be the role of hormones and connective tissue. Do you have an opinion on that?
So I had kind of a streak when I first opened my clinic of young ladies coming in that were on Depo-Provera. And I wasn't a fan of that because of the fact that it was, every 3 months, and then, you can't control it in between. And I just saw back one of these young ladies. I've been seeing her now for 4 years.
Uh-oh.
And knock on wood, not that I'm gonna like jinx her now or anything. Oh, something happened.
Well, it's
We
okay.
okay?
You're back.
Okay. Anyway, she's doing great. And I asked her specifically, how are your periods? One of the things I know that we first worked on was getting you off of the Depo-Provera, and we worked on a number of other different things. At one point, I mean, she was even looking at having cervical fusion surgery because it seemed like her neck was so unstable. She was having a lot of symptoms that could be related to Chiari malformation, et cetera. She never had any of those surgeries. We got her symptoms under much better control, and she's not on anything hormonally right now. And she's doing great. She's back in college and actually has a little business on the side, and is on a fraction of the medications that she was on before. I wish every case was, super successful like that, but hormones are definitely really tricky, right? And so it's one of those things that, sometimes it can be hard to unpack. What does this person need? And I'm not a gynecologist, so I don't want to, I always want to be careful to stay in my lane. But it's also hard if they're going to a gynecologist that, is not real familiar with mast cell activation syndrome or EDS or any of those other things. Although I do tell my patients, I'll talk to your other doctors. I'm happy to talk to them so that we can together, come up with a better game plan.
If I can chime in on this, progestins are notorious muscle relaxants, right? And one of the reasons why sometimes progestins benefit people with pelvic pain is that because they do relax those muscles. But in the case of somebody who has a connective tissue disorder, it could be that the additional pelvic relaxation could actually be a greater problem. So, one could hypothesize, excuse me, one could hypothesize that the progestin in these circumstances is actually contraindicated. I mean, makes sense, right?
Mm-hmm. Yeah.
Yeah.
And it's very common for patients to report a significant increase in their symptoms and a significant increase in their joint laxity, shortly before their cycle starts. And, in pregnancy, they experience, significant difference with their symptoms. And then sometimes when they go through menopause, actually their symptoms might improve somewhat. So we definitely know that, and that's the other thing is when I go through a timetable with people, it's not uncommon that they were doing fairly well, and then their menses started, and that's when things really started to go awry. So hormones, I believe, are extremely important in these conditions, extremely important.
Yeah. And then I think about if you throw a couple cycles of IVF into the mix, really what, there are people, the doctors, sorry, Dr. Vidali, they like to say like, whatever, it doesn't do anything. I have had plenty of patients through the years who say like, it was the IVF that tipped them over the edge. with connective
I
tissue.
talked to somebody tonight, to two people tonight, a little earlier, who had exactly the same experience, to be honest with you. IVF throws off endometriosis, but we're not talking about that tonight. Sorry.
We will, though. We love to talk about that.
Yeah.
Right. So I wonder, like, in terms of lifestyle changes, when you're dealing with connective tissue, I mean, I'm a PT, so a physical therapist, so I approach it very differently than you. But how do you sort of like delve deep with what somebody can do in terms of lifestyle changes?
So I have a mnemonic that I use that I think I mentioned during our
Sure.
podcast interview, and it just helps me to remember there's a lot of other things besides medications or supplements, and it's men's PMMS. And the first M stands for movement. The number one most important thing is for people to move as much as they possibly can safely with good movement patterns, and working with a trained physical therapist who can really customize and individualize your treatment program is absolutely essential. I've been in and out of physical therapy since I was a teenager, and without my physical therapist, I would not be sitting here, doing as well as I am today. There's no doubt whatsoever in my mind. So whether it's physical therapy, occupational therapy, Pilates, gyrotonics, going for walks, doing some exercise videos that are safe and good for your body, but we need to move. Our bodies were meant to move. Our fascia was meant to move. It's so, so important. So
now,
you wanna say
fascia,
something there,
and
Sally?
right, I do, because I think it's important to point something out, that every doctor in the world says to all my pelvic pain patients, go do yoga. It's so good for pelvic pain. And it's really not always great for the connective tissue crowd. Do you find that as well?
Well, the hard thing about yoga, and the hard thing about a class in general, is you often will be paying so much attention to following the instructor, what's going on around you. There's peer pressure. And so you will end up doing things that your body really should not do. So I often tell my patients, don't start with classes, start with one-on-one movement wherever you possibly can. And then, if and when you decide that you can do some type of a class, talk to the instructor beforehand, let them know I will be making some modifications, some adaptations. So if you see me doing something slightly different, it's not because I didn't understand the instructions, probably. It's because, I think this is something that I need to do for my body. So, I think yoga, I don't think there's any single modality that is an absolute no. Well, I shouldn't say that, maybe like, some really extreme or collision type sports, we do have to be careful with those. Yeah.
No collision sports.
Yeah. So we used to call them contact sports, but now we're supposed to call them collision sports, and for good reason. But yoga, I think it depends on how you're doing it. And I actually have a friend who is a neurosurgeon and a functional medicine doctor and a yoga instructor, which is obviously a very interesting combination. And he developed a program for yoga with people with EDS. And he ran me through it and customized for me, my body, the exercises. And I felt great after I did that. And it really, was a really great way to do more like medical yoga, but if you walk into a studio where the instructor maybe hasn't had anywhere near as much training, and you're in a group setting, you definitely can hurt yourself, especially if, people who are bendy are going to be able to get into poses that maybe are not using the correct muscles. So they're not using the deep stabilizing muscles. They might not have their, the head of the humerus actually in proper alignment, in their shoulder. So instead they're subluxing their shoulder while they're doing that movement. And at the time, it might not feel bad. It's not until the next day that they realize, man, I really hurt my shoulder. And then they decide that yoga is not a good idea, which maybe they're correct, but done properly, I think there's a lot of things that we can do that can be helpful.
Yeah, I think it's, I always get this patient. We have somebody in the comments who's doing it. movement hurts. I have endo, I have EDS, I got to lay down. I can't do anything. And so my answer to that as a physical therapist is movement is movement. It doesn't have to be 45 minutes. And actually, I had to take all this continuing ed to renew my license in 3 states. Very fun. So what I learned was the research on just 10 minutes of movement, excuse me, is just as good as 30 minutes of movement. And so taking movement snacks is extremely effective, and you should work with somebody that helps you figure out the snack for you. Anyway, I interrupted you. What is the rest of your acronym?
Okay. So I just want to add on to the movement piece that if we don't move, then we get even more deconditioned, and that makes the dysautonomia worse. And it just, the whole cycle and that makes our pain perceptions worse. So that's why movement is absolutely number one. Okay. So movement is number one. Then the E stands for education. I believe very, very strongly that if patients understand, pain processing, how that works, why sometimes pain does not equal damage. So you might feel more pain because you are stressed, you're anxious, you are, anticipating something, really scary. And so you are feeling more pain. And so it's important to understand how the nervous system works and why we need to take the information that our body is giving us and teach ourselves how to interpret those pain signals. And I encourage people to have a curious mindset more so than an anxious mindset. It's extremely common to have anxiety if we have hypermobility disorders. That's a very, very common comorbidity. And so it can be very hard to do this, but when people are able to approach things with a more, more of a curiosity and, well, let's see how I should adapt things, then that can tend to help. The N stands for nutrition. So I believe very, very firmly in people, balancing. What's important to have, in dance, I work with a lot of dancers, and eating disorders are very, very common. So we have to also be very careful that we don't get overly restrictive, but we do want to think about what are we eating and how could that possibly be contributing to our symptoms. So the S then stands for sleep. Sleep is critically important. If we don't get good sleep, then that increases our pain, which makes our sleep worse, which makes our pain worse. And it just turns into a vicious cycle. You can substitute pain with anxiety, and you're going to get that same vicious cycle. So it's really, really important to do work on restorative sleep. And I have lots of patients who they'll go to bed at 2 a.m. So one of the first things that we do is we talk about the circadian rhythm and how important it is to get to bed at a reasonable time so that you can get your body on the right timetable as best as you can, and actually be able to have a more appropriate modulation of your nervous system. So then the P stands for psychosocial. Now we're on the PMMS part. The P stands for psychosocial. It's extremely important to address any anxiety, depression, catastrophization, trauma. It is very, very common for people to have trauma in their history. It could be ACE, adverse childhood experiences. It could be medically induced trauma, as Dr. Vitale was talking about at the beginning. There's lots of people that have had, some pretty traumatic healthcare experiences of various different sorts. And so we want to address any trauma or other factors that can be contributing to their symptoms. Maybe they don't have a very supportive home environment, and it can be very, very challenging. Maybe a person is in so much pain, they're really focusing inward on their pain levels, and they're not able to work, and their spouse is like, this isn't what I signed up for, and they're like, hey, for better or for worse, I've been in the room with lots of some interesting encounters, but I can understand from both sides, it's really, really difficult. So sometimes couples therapy is important, individual counseling, et cetera. And then the next M stands for modalities. So that could be acupuncture, acupressure, ultrasound, all kinds of different, Reiki, I'm not sure how you pronounce that exactly, craniosacral therapy, things like that. And then the next M stands for medications. It is at the end on purpose. And then the last letter is S for supplements. We want to have a really good diet because there's no amount of supplements that are going to make up for a bad diet, but sometimes supplementation can be helpful in order to get the body into better homeostasis and, have better control of symptoms.
Yeah, I wonder, we have
And we're going to talk about a lot of these at the summit, right? We're going to discuss these in more detail at the summit as well.
Yes.
I think, it's a good opportunity to talk about that also, I think.
we
We don't
do
have a lot
not,
of time, but I just want to mention.
not to leave it out though. Dr. Bluestein did discuss it very extensively in the podcast she did with us. So anyone who is missing that, you can hear the Endometriosis Summit podcast pretty much on any podcast channel. So many questions about like optimizing the gut. Do you have, I know it's so individual, but do you have any generalized rule on how you work with people with diet?
So one of the things that I look for, two things. One, does it appear that they're getting the nutrients that they need? Because sometimes it's don't eat this, don't eat this, don't eat that. And it's like, well, but you need nutrients in your diet. You need and when I say diet, I just mean the foods that you eat. I don't mean diet as in Weight Watchers, kind of a thing. So it's really important to look at, are they meeting the macronutrients? Are they getting the appropriate amount of carbs, proteins, and fat? And does it appear that they're getting the appropriate micronutrients? So does it appear that they're getting, omega-3 fatty acids? Are they getting B vitamins? I've had patients that are like, I'm thinking of this one particular patient who was vegan, and she ate Captain Crunch cereal for breakfast and lunch, and dinner wasn't much better. And it's like, that is.
While I have him here, Dr. Vidali, your opinion on vegans and connective tissue, because the two of you could have a good time with this.
Well, first of all, I don't, there's two reasons. I would say that if being a vegetarian in general is obviously from a health standpoint is a good idea. But being a vegan, in my personal medical opinion, I think that you're preventing yourself from certain nutrients that you could only get by eating animal protein. Now, if you're a vegan for ideological reasons, there's nothing I can say about that. Of course, it's an ideological choice, which has nothing to do with what we're talking about here today. Ideology is different. It's an idea, principle. But from a purely health standpoint, as a surgeon, and I share all this observation with many surgeons every single time I can, we notice that the tissue, the connective tissue in people who are vegan appears to be more brittle. Tissue just tears apart.
Interesting.
And it's an observation of a surgeon, but I share it with every surgeon I see. So for what it's worth, it's not hardcore science, right? It's just an observation. So don't, I admit to it, but it's something that I see. And and that's, it's just an observation for whatever it's worth.
Yeah, very interesting.
But somebody who's been doing this for a long time, who has shared this opinion with many, many surgeons, and they're like, yeah, that's true. So I don't know how you feel about that, Dr. Bluestein, but maybe you feel the same way.
So it's interesting because when I was working as an anesthesiologist, I knew a fraction of what I know now about connective tissue disorders. I barely knew that I had one by the time that I was, I had a big surgery on I had a huge cyst inside my lunate that I had bone grafting surgery for, and that kind of led to CRPS and other complications, and that led to this career change. But my husband is a surgeon, and he's a urologist actually. And I know he has told me before, not sharing the patient's name, but he'll come home and, oh, that case was so hard. The person's tissue just fell apart. Every time I went to put a stitch in, the tissue just fell apart. And then of course I'd be like, well, wait, I need to know more.
But I've stood in the OR and I'm not even Dr. Vidali, but the general surgeon, they'll go in and and the tissue's falling apart, and the general surgeon will yell, "Is she a vegetarian?" You know,
Really?
I know.
so I think this is like a hidden thing that surgeons talk about. And you're right, people have their own ideology and people have their own reasons. My cardiologist would probably love for me to be vegan, never gonna happen. But you know, it does affect you. You mentioned CRPS. Is there a connection between that and connective tissue disorders? Because somebody asked me that on Instagram today.
Sure. So I don't know any statistics, but we do believe that all kinds of neurologic pain syndromes are more common in people that have EDS. So we know that, you know, there's nociceptive pain, there's neuropathic pain, and then there is nociplastic pain or centrally mediated pain. And it does appear that conditions like CRPS or complex regional pain syndrome are more common in people that have EDS.
Yeah, very, very interesting. We have a lot of questions, and Dr. Vidali wanted to answer it live because he typed that into the box.
No, I just wanted to thank that person because that
Oh,
was a person said lots of information. Thank you, Endo Summit. And it's true. I mean, I think that as an organization, the Endo Summit, and thanks to you, Sally, obviously, you know, we do try to bring, you know, people that are in the know, people, ideas that are not shared in most meetings, you know, even major surgical meetings. I just came back from AGL, which is a great organization, but you know, you don't really hear people talking about this stuff, right? You know, like, you know,
Right.
it's something that, you know, like, you know, unless you have these secret connections that you know some people that know people. I know a doc, you know, somebody just asked, you know, just wanted to circle back to about
I
how do I
wasn't.
find doctors.
Oh, well, that's a good one. Okay, do that one. I wasn't done, you know, asking. I was going to do that one
Sorry.
last.
Oh yeah, sorry, yeah.
Yeah.
How do I find doctors who specialize in this? You know, like good, very good question. I think, you know, of course, you could go to Dr. Blaustein's website, right? I just you know, which is very informative. But you know, let's say that you are, you know, you're wherever you are, you can't travel that much, you know, and you're not in a major academic area where there's like a lot of academic institutions. And you know, are doctors who specialize in academic institutions? Sometimes they are, sometimes they aren't. One of the problems, you know, in my experience, and please correct me if I'm wrong, usually the people who understand, who have a better understanding of connective tissue disorders associated with mast cell activation syndrome are usually allergy specialists, allergologists. But most of them only deal with asthma, so you got to find the right ones. But
Yeah.
that's really where, you know, there is a mast cell activation syndrome society, and they do have a decent website, I think. But you know, it's hard, and there's long waiting lists, not just in Canada.
I also was blown away, Dr. Vidali. We're having your residency buddy, Dr. Patty, right?
Yes.
And she has her own society, and we had a long conversation because she does a lot of connective tissue work because she's functional medicine. But these are great questions to ask at the Endometriosis Summit. I just found like we added Dr. Bluestein into the mix because I felt as a patient and as a physical therapist, if we weren't talking about this, then we weren't servicing the endometriosis crowd in full, right? So that's why we did that. But the other thing I found fascinating, you did a chapter in a book, which I remember you mentioned on a podcast, but I can't remember the name of the book. And for the patient, when you talk about that E in the men's PMMS, yeah, this is very interesting, this book. Do you want to tell people about that?
Show it a little bit more, doctor. Please show it again.
Sure.
Show it again.
It's called Disjointed, Navigating the Diagnosis and Management of Hypermobile Ehlers-Danos Syndrome and Hypermobility Spectrum Disorders. And I wrote 2 chapters in this book. I wrote the chapter on anesthesia for this group of patients. And I also wrote a chapter on pain management in the book. The editor of this book, Diana Joven, did the most amazing thing. She managed to get over 20 different specialists to write chapters we all volunteered our time. I get absolutely nothing from the proceeds of the sales of the book. And it really is, I think, a great resource. And it is now available as this paperback that I just showed. It also is available as an ebook, and it is available in, multiple different countries. There's a link on my website if people are interested to learn more. And
yeah,
as I
we
said,
got to put it. We got to put it up on our website. I have to tell you, as a PT, I heard you talk about it in a podcast. It changed how I thought about the human body. It's really, and I know you don't make any money on it because you said that in the podcast too, but it's really, really an important read. I think, especially if you have to go into the doctor and advocate for yourself.
Mm-hmm.
Yeah, so I wanted to talk because you're anesthesia and you're also a HypermobilityMD, really, and you created that field, I believe. But let's talk a little bit before we head out on healing from surgery. I feel like the EDS and the hypermobile population, they have to be a little bit, because they're transferred on the table under anesthesia. I know Dr. Vidali is obsessive about where he puts the stirrups because you could hurt the hip. I know I've seen patients who've had rib cage subluxations, and I've seen the mast cell people. You have to be very careful with the adhesives. What are some of the things the surgery crowd and connective tissue disorder crowd should watch out for, doctor?
So I do want to mention, before I even mention any specifics, I did write a peer review paper on the same topic with Dr. Pradeep Chopra, and it is open access. And sadly, when he and I were writing this paper, we submitted it to probably 8 or so journals. And, we eventually got it published, of course, but the first 8 or so, turned us away because they said, nah, that's too rare. Nobody, our crowd doesn't want to read about that. It's not important enough. And I was just devastated by all of that, because I thought, oh my gosh, back when I was practicing in the operating room, I wish I had been as aware as I am now about the potential to sublux someone's joints after you put them under general anesthesia and then you move them over. And I certainly didn't ask those questions. And the pressure, the production pressure is tremendous. So I often will write letters for my patients, and I kind of stipulate on there, like, what are the joints that are, most loose. I have things divided into like airway considerations, positioning considerations, post-op considerations, wound healing. And then also, if they have dysautonomia, that has implications, of course. And if they have mast cell activation, that also has implications. I have to confess, when I was practicing in the operating room and I would be pre-opping a patient, and I would see that they had a list of 20 different drug intolerances and allergies, I thought, oh, that can't be. And now because I didn't know what excipients were back then. Now I understand that is, it is possible, and it is likely because of these excipients and or because this person, their mast cells are so pissed off that they just have very little tolerance for things. So, things like So things like, neck pain, that in somebody without a connective tissue disorder, if they don't have radicular symptoms, meaning they don't have pain that, goes down a predictable pattern in their upper extremities, maybe you don't have to be as concerned about positioning the head for endotracheal intubation. But if someone has a connective tissue disorder, we should be taking a more detailed history so that we can manipulate the head and neck and establish an airway in the safest possible way. So there are a lot of things to consider. And fortunately, now we have things like the video laryngoscope, which gives us the ability to manipulate the head the head and neck less than we used to have to with direct laryngoscopy. But these are things that most anesthesiologists aren't at all aware about. And in their quick, review of the patient, and oh, this is the procedure, this is the position.
Like 5 minutes.
Yeah, exactly.
Like 3 minutes. Yes.
Yeah, exactly. So,
But I would go beyond that, doctor. What I would say is that always assume that you could do damage when the patient is asleep. Always assume, always be careful with everybody, regardless of the history.
yeah.
And I have walked into ORs where people are doing gynecological surgery, and of course, I see more gynecological surgery, and I see people lifting those stirrups up to the sky like that. Boom! I see this stuff all the time, and it's crazy. And then like it's just like we always assume that you could do damage when the patient is asleep and paralyzed.
Mhm.
That's the way I would take it to that level personally, and certainly
Sure.
that's my standard. And I think it should be everybody's standard, in my opinion.
Do
Yeah.
you feel, Dr. Vidali, the fact that you work with almost the same team all the time helps you maintain that safety on the table?
It does, but like I said, it has to. Forget about me personally. I mean, I think it just to be a standard in general, and for sure, like it's just like, and let's not even talk about childbirth, where people think that the only thing that matters is the baby comes out. Doesn't matter how. You know what I'm saying? Like the success stories, the baby came out. I mean, forget about the damage that gets done throughout the process. With the knees pushed behind the ears, and also crazy stuff that happens in delivery rooms. Unbelievable stuff. Unbelievable. Anyway, but that's another story, right?
Definitely.
But
Yeah, so we're winding down our hour. We're over our hour, but so I wanted Dr. Bluestein is headed to the Endometriosis Summit for a full 1 hour workshop on connective tissue, and she's going to be amazing. And Endo Summit workshop will also have almost 3 hours on the gut and bowel. We're going to have somebody on hormones. We're going to have a full afternoon on trauma. I'm going to do biomedical versus biopsychosocial, and it's going to be all interactive, whether you're online or in person. But you are new a little bit to the Endometriosis Summit. What are you looking forward to about our conference, February 18th through the 20th?
So I feel like the first half of my career, I was very isolated. I hung out with all my anesthesiologist friends. I interacted with the surgeons, of course, but things were very, it was very traditional. And now I love interfacing and interacting with other specialists who are seeing things from a different perspective and getting to discuss some of the things that we encounter in medicine, and hearing different perspectives is so important and really helps us to grow. And I'm really excited about that aspect, because I feel like you really are presenting this really unique way of both for the participants and for the presenters to really connect things that they may not have connected before, and really learn in such a unique way. It's really a great thing. I'm really excited about it.
Oh, thank you. We had like team urology on, and they said the same thing. He said, it's the first conference in endometriosis where the urologist is like front and center. Now that's because we happen to like Dr. Lariche, but also because, that's an important role. Then last week we had team hernia on, a physiatrist, a PT, and a general surgeon. And they were like, this is usually the only conference on endometriosis we're invited to all year. And so now we have you on. So I've obviously understood the assignment when it came to multidisciplinary care. So it makes me feel good. Dr. Vidali, you are your first Endo Summit Live of the season. So tell us, what are you most looking forward to about the Endometriosis Summit, February 18th through the 20th?
Well, I have to say, I learned something new every year. The key in what we do here is that and when I say we, I also mean you and I, and everybody who participate in this as faculty, we want to learn. We don't want to just teach people or tell people, Sherman. We want to learn. Like I learned a lot tonight. and I'm grateful for that. And thank you. I hope I can call you Linda. Thank you, Linda.
Of course.
I really am thankful that you're here with us tonight, and you have helped us open our eyes even more. And I'm looking forward to open my eyes wider every time and every year with the Endometriosis Summit. That's what I'm looking forward to.
Yes. So if you would like tickets to the Endometriosis Summit, it's www.theendometriosissummit.com. You can come to the conference here with us in Florida, or you can get almost the entire conference except for one lab available online, so you can attend virtually. You can attend in your pajamas with a blanket, which we did it virtually last year and because of COVID, but I didn't realize how many don't want to flare from traveling. So this is a permanent thing. We're always going to offer something virtually because we have to cater to our crowd. You can have all your good gluten-free snacks and a blanket and the dog, and it's like the best. And or you can come in person and have the mayhem of the whole community being there. We have to see how things play out. Okay. But you can come both ways, and tickets are on sale. And as we are signing off, how can people get in touch with you, Dr. Bluestein?
So I'm probably most active on Instagram, and my handle there is at HypermobilityMD, and the Bendy Bodies is at Bendy_bodies. And then my website is HypermobilityMD.com. I am also active on Twitter, Facebook, LinkedIn.
I found her on Clubhouse.
Yeah, I haven't been. I am so glad we met on Clubhouse because I have not been on there much lately, but yes, we met on Clubhouse. And so I all of those places, I'm HypermobilityMD.
Yeah. So, I mean, it's just fantastic to have you. We're going to have more collabs. Hopefully we'll go back to Clubhouse maybe in the spring. But it'll be great. We just, best Clubhouse I ever attended was when we met, because I bought that book. I listened to all the Bendy Bodies. I learned a lot. So we're wrapping up tonight. The recording will sit on YouTube. We will be back at you next Monday night with Dr. Francisco Garcini and Maurice Chung. And it's very interesting. Dr. Garcini is going to go over, he does a special checklist with teens with endometriosis. And also those are my buds. So it'll be nice, even though I can't be all together in person, that will be all together online. So we will see you next week, and take care, everybody.
Thank you so much for having me.
Thank
Great
you.
to meet you.
Thank
Dr.
you. Thank you. Thank you. Pleasure. Thank you, Sally.
Thank you.